keeping an eye on imaging. Discussion and commentary based on articles from JACC, Cardiovascular Imaging.
Good morning. I'm Jagat Nerula in the CVN studios, today with Dr. Ahmed Tawakkul from Mass General Hospital, Boston. Welcome, Dr. Tawakkul, to the CVN.
Thank you for having me.
We are publishing an excellent study from your group on the molecular imaging of coronary inflammation in the next issue of Journal of American College of Cardiology, Cardiovascular Imaging. Various histomorphology reports have demonstrated that the necrotic core volume or the necrotic core size and the extent of plaque inflammation are the best determinants of the plaque instability. While the CT angiography and the magnetic resonance imaging demonstrate the plaque size and the necrotic core volumes quite well, molecular imaging has remained the mainstay of detection of the plaque inflammation. In the carotid inflammation, which was first proposed by Dr. Fuster and Dr. Vallabh Josula in 1997, it has taken us almost a decade to come to some kind of a clinical maturity. Your group has earlier demonstrated that the carotid inflammation can be detected by the FDG imaging. It is positive predominantly in the symptomatic patients, resolves in response to the statins, and the uptake can be easily traced to the macrophages. Now that we know all that, what do you think we are going? Where are we going? And what exactly would be the clinical utility of the carotid inflammation imaging?
There are certainly many steps that need to be taken before we can apply it clinically, but there are certain early steps that I think could be useful. For example, we might envision using FDG PET imaging of the carotids to better stratify patients with asymptomatic disease who have moderate carotid stenosis. In those patients, there's often a quandary in deciding between medical therapy or surgery, and I could potentially envision a day where a high signal in the carotids in those patients might lead us towards a more aggressive intervention. On the other hand, if we were to find that risk stratification was very powerful using this technique in the carotids in particular, we might reach a stage where we would identify patients with moderate to severe carotid stenosis who has a very quiescent plaque and maybe determine that careful follow-up and watching the carotid is a reasonable way to go with medical intervention to reduce progression.
The recent study of yours, which would be coming in the JACC imaging in the April issue, and I think it is one of the best studies in the molecular imaging that I have seen in the recent years. You demonstrate that even the localization of the plaque inflammation in coronaries would be a feasibility. And I know that you have used some cumbersome procedures in there. You have tried to clean up the myocardium of the FDG uptake. You have tried to use the CT angiography as the landmark and use the stents in the patients with acute coronary syndromes as the landmark for the localization of this inflammation. Do you think that this is actually going to become a technique which would be possible in a clinical scenario? And if yes, what is going to be the use in coronary imaging as well?
I think there are going to need to be several refinements in the technique before it could be clinically applied. First of all, there are many investigations into better tracers, more specific tracers, where these cumbersome methods of, as you put it, cleaning up the myocardium will not be necessary. We'll need better ways to actually freeze the myocardium itself, freeze the heart, so that we can better measure the small foci of inflammation that we need to see with the PET imaging technique. Also, there are better cameras that are being produced, better PET CTs and new PET MRs that might come to bear on imaging of the myocardium and the coronaries. At the end, though, I think one of the most important steps that needs to be taken is a better understanding of the value of inflammation imaging in the coronaries, or at anywhere for that matter. Is it a local biomarker? Is it a systemic biomarker? Is it a cost-effective biomarker? But if we find that it is a cost-effective biomarker in the coronaries, it might actually be a very important tool down the line. We might be able to go beyond a single therapeutic avenue for all our patients with coronary syndromes and be able to better specify which therapies, tailor them, akin to the way an oncologist might tailor their therapies. So there are lots of hurdles, but I think the eventual potential benefit could be great as well.
Thank you, Dr. Tawakul, for the excellent overview of your study. And I believe it would become a one-stop shop for all. And congratulations for your studies, and thank you very much once again being with us.
Thank you so much for the opportunity.
Thank you.